Good morning, everybody. Can I go off mic? Can everyone hear me?
Yeah.
Okay. So I am very excited to be here in Toronto. Greetings from New York City. I work for the Medicis Health Network, which is a agency that has 2 hospitals, 1 nursing home, and an EMS agency. And today I'm going to be talking to you some research that we've done at one of those sites. So my name is Kevin Lalonica. I function as the Assistant Director for Professional Development at Flushing Hospital. At the time of this study, I was the clinical nurse manager at the emergency department at Jamaica Hospital. So I don't know, is anyone a New York person here? Where at?
Elm.
In Elmont.
Oh, so I know Jamaica.
Oh, there. Oh, very good. Are you at one of the North Wales?
Oh, I used to. I'm at the VA.
Welcome. Thank you so much. So, what we are talking about today, development and implementation of a nurse-led ultrasound-guided peripheral IV access program using a novel DIVA score. So I just want to make sure that everyone is in the right room. Is anyone here an emergency nurse or ever functioned as an emergency nurse? Okay, good. For anyone who didn't raise their hand, are you a healthcare provider that has ever had to put an ID in a patient?
Yeah, I do.
Everybody else, right? Did I miss anybody? You didn't raise your hand. Are you a human being who does not like to be stuck with needles? Then you are in the right room. Okay, so DIVA. So what the point of this talk and the study was around this term DIVA, which is not just a descriptor for my 8-year-old daughter's personality. It stands for difficult IV access. So this all stemmed, I'm going to take you on the journey back with me. So when I started at this emergency department in a leadership role, it was very important to me for the nurses to be able to perform ultrasound-guided peripheral IV access for the primary reason of it being completely selfish and just a really cool thing that I like to do and brought with me. And I said, why don't you guys do it here? And they said, we've never really looked into it. Okay, so why is this important? So the emergency department that I'm using as the background for this study is, like I said, the Jamaica Hospital Medical Center, which is one of the level 1 trauma centers in Queens, which is a borough of New York City. And we see approximately 120,000 visits per year, which equates to 300 emergency department visits every day. Out of those 300 souls that walk through our door, about 85% all need IV access for some reason or another. And especially for the emergency nurses in the room, you know that not having IV access is a complete bottleneck. If you do not have IV access, you cannot give medications, you cannot give fluids. That is usually how we draw our initial labs. So everything gets a massive slowdown when you don't have your IV. And difficult IV access is a term that probably many are familiar with because the population, and I'm speaking from a U.S. perspective, I know this is an international conference. In the U.S. perspective, difficult IV access is a skyrocketing problem because our population is living longer. They are living longer with chronic disease, and those chronic diseases wreak havoc on our vascular system. And also, the older we get, the more we have to be pushed into the healthcare system, and the more times our things get accessed over and over and over again, which also is a contributor. So what we noticed in our study, between 10 and 24% of all the ED patients are some variation of difficult IV access. And we know as healthcare providers that stick patients with sharp things that multiple failed IV attempts cause pain, cause delays, and worsen our patient experience. So I don't think this is so true anymore, but it was still in the literature that it also leads to unnecessary central line access. So when I was coming up, I originally functioned in healthcare as a paramedic. So I was always, if not in an emergency department, around the emergency department. And especially back in my paramedic days, when we would bring in patients that were difficult IV access that needed emergent treatment, and nurse took 1 or 2 shots at IVs, we would have to have the physician place a emergent central line. And we know that central venous access brings the risks of things like central line associated bloodstream infections. Depending on where you're putting the line, sometimes we drop a lung and cause a pneumothorax, and also invasive lines give us an increased risk for thrombosis. Okay, so what was the major issue with this? So out of those 300 souls that we had come to our emergency department a day, 85% needing IV access, about maybe 9 to 10% per day were difficult IV access that required multiple IV attempts by the nursing staff. What was the initial barrier to getting this done? Traditionally, physicians were the only people doing ultrasound guided IVs. And even though many departments in the US and in New York specifically are adopting for nurses to learn this skill, and like we did at our facility, to be developed protocols and a policy, which the policy part was one of the most difficult things to institute, but it was the most important thing to institute to allow the nurses to do this procedure. It was typically kind of locked behind the physician wall. And at our facility in particular, we would have maybe at the peak time of the day, maybe 5 to 7 physicians on, but over 30 nurses. So when you have that kind of ratio, you cannot always depend on the physician to have the time to do it, or at least not in a timely manner. We had definitely more nursing capabilities than we had physician capabilities to do this procedure when needed. So we had to overcome that. Also, we have a lot of physicians that were not new emergency physicians that were trained in ultrasound as part of their residency cohort to begin with. So their comfort level with performing this procedure was, quite honestly, not much better than an inexperienced nurse. So just to keep that in mind. So did we reinvent the wheel by inventing a DIVA score? No. There were other difficult IV access scoring mechanisms and tools out there, such as the A-DIVA and the M-DIVA. So what made a difference was both of those scores were non-nursing driven, and they were also very dependent on the clinician examining the patient. So plain terms, pretty much you were not known to be difficult at IV access or having high potential of being so until the nurse sat down, did your interview at the bedside in the ED with the tourniquet around your arm looking for a VINI. So some of the criteria that they looked for was, I put the tourniquet on, is it visible? Is it palpable? Things that were really basic. And the question that I wanted to answer is, was there a mechanism that we could utilize to determine if someone was going to be a difficult IV stick right from the point of triage? Upon your presentation, what was the likelihood of me needing to bring an ultrasound to your bedside at some point? Because I think anyone who especially worked ED knows that when you have a difficult IV access patient already in your day or your district, whatever you called it, how it usually worked is you took 2 attempts or 3 attempts, and then your nurse that was right next to you, working alongside you, be like, hey, this guy's really difficult, can you try? And that's how it would usually go. And before you know it, this patient is 3, 4, 5, 6, 10 sticks in, and no IV access has been had. So wouldn't it be cool if we had a tool that we, right from the get-go, right from arrival at triage, we could say, you know what, the likelihood of this patient being difficult is high. Maybe we want to move the ultrasound up and get someone who's trained in that to the bedside sooner than later. Okay, so how did we do this? We did a retrospective chart review of approximately 53 patients that all underwent ultrasound-guided IV placement. And what we were able to do is to pick their charts apart and identify the characteristics that were common to say that they were difficult to IV access, and we'll be going over that shortly. The next thing we needed to do was develop a training mechanism for the nurses to become familiar with ultrasound, understand when it is advised to use it, the pros and pitfalls of utilization, and in the actual procedure of ultrasound-guided IVs. And then we had to expand the program. So after we had people trained and a scoring tool to utilize, we were then off to the races. And this is what we delineated from our research, was we were actually able to determine these factors as being high risk for difficult IV access. So this is not going to sound obscene to anyone. The elderly, age over 70, people with BMIs over 30, so overweight. Are they a patient with diabetes mellitus? Do they have hypertension, which wreaks havoc on your vascular system? History of IV drug use, which was in there and very intuitive, and actually, when we got down to it, was one of the least identified factors. End-stage renal disease with or without dialysis, and active cancer with or without chemotherapy. The factor that was the biggest was history of difficult IV access, which was just a subjective question that the triage nurse would ask, but it was the most heavily weighted because the past dictated the future. If somebody said they were typically a difficult stick in the emergency department, they were probably going to be that way today. All right, so people that scored 0 to 3, we considered low risk, and our advisement was that they would utilize their traditional techniques. And we people that were moderate risk, 4 to 6, we would advise that you might want to use it on your first attempt or your second. And anyone high risk, we would very strongly advocate for you to get someone ultrasound trained in the ultrasound machine to be their first attempt. So we did this, we built this methodology through several steps. So initially a literature review, and I told you that we identified other DIVA scores and we tried to see where our particular patient cohort would actually fall into that, and we ended up making our own. We did our chart review of our initial 53 difficult IV access patients. We were able to identify our 8 variables that were almost all historically based, which was very interesting because it's the information that a triage nurse is taking in anyway. So it was no real add to their workload. And then we did our pilot validation. Okay, so for our training, this is not atypical for anyone who has done a ultrasound course at their facility. We went over the physics of ultrasound, why it's useful, typical vascular anatomy that the nurse would utilize, typically upper extremity vessels, how to actually use the variety of machines. We did some supervised simulated cannulations, as well as upon completion, they at least had to do 5 witnessed IV cannulations with ultrasound for difficult IV access patients before they were free to perform this procedure independently. So how did our scoring fare against the other tools that were out there? So when we look at our ROC curve, we saw that our tool for DIVA outperformed what was known as the MDIVA score for our particular patient population, which was very interesting to us and very valuable because it was something that we could use, like I said, to identify patients sooner than later and before they had multiple IV attempts. All right. So what I always like to bring to everyone's attention with this study was the patients, as suspected in hypothesis, that the people that ranked higher on their DIVA score with us obviously were the higher sticks. 46% as opposed to a low score was 8.2%. And this is my favorite, is people that were identified as difficult IV access were anywhere along that scoring mechanism of 0 through 9. They had an average 4.2 sticks before successful access. And when we instituted this program, we got it down to 1.1. So we had over an 80% reduction in IV attempts just by utilizing the information from this study. So what do you need to know? Was this dangerous to perform? It was not. We had 0 complications that we would consider major. So none of these complications consisting of arterial puncture, unnoticed infiltration of vesicants, things along that lines, 0 major complications. During the actual study period, which went on for 6 months, we got a pretty much 450 cannulations. 88% were first-time sticks. And that's just not, I'm a great ER nurse and I put it in 90% of the time. It was with the difficult people that we've already identified, it went up to basically 90% of the time. So very valuable data that we found. Okay. So we noticed that information stayed consistent at 88 to 90% of the time. One thing that we found, secondary data, was that these difficult IV access patients that we identified using our score, these patients were 60% of the time the patients that were admitted to the hospital. So we were doing this procedure on patients that didn't just need IV access for their 4-hour ER visit. The majority of the time it was for patients that were going to be staying with us long term, and now they have IV access for the most part, the majority of their hospitalization. We did not have to change these lines. As opposed to our normal ED admission rate of 28%. So that's just a reiteration of the same point. So what was this good for nurses? This gave them an expanded scope of practice. They got to learn and perfect a new skill. It gave institutional confidence to allow nurses to not only run a research project, but to adopt a new patient care-centered skill. And we realized that this was a safe practice, and we did not have to deal with the same resource optimization issue of the provider being available to perform this skill. Okay. Like I said, we're empowering nurses, which is very important to everybody. It was only a single center study. Where we're going with this future, we are now expanding this to our other site. And if anyone is keeping track of this, and hopefully this will be published sooner than later, we plan to broaden this study to see how it is going to play out at other facilities. So no major complications, almost 90% effective in first-time stick, and we were able to empower nurses, not only in our initial ultrasound group, but we got to add to that. Everyone wanted to be a part of it when we were done. Thank you so much for your attention. It greatly appreciated. I really like. Do you hear that, everyone? Any questions?
Any questions?